I think you can see from the conversations we've had so far that this is all about patient selection. If you don't select the right patients, if the patient doesn't have the disease, they're not going to get better. But there are plenty of publications out there of series of tethered cord, and they're all better than 90% success. So it's hard to argue whether or not this works. It's just all about selecting the right patients. And the problem with it is that you can't look at one piece and make the decision. You have to spend an hour and a half in the room with the patient, doing a detailed exam, looking at all the studies. I've had some patients I've waited 5 years before I've been able to make the diagnosis because I wasn't convinced. And our percentage of success is very high because we only do kids that we're really sure have the problem. And so when Paulo asked me if I would talk about this, I figured, well, what would be the best thing to do? So I went back to the talk I gave in 2000 at a neurosurgery meeting of 60 patients, and I started, my very first talk was in 98, and that was only 17, so this was looking more at the criteria that we use, and this was a series of 60. I don't have any disclosures. And so by introduction, tethered cord syndrome often presents as urinary instability with a neurogenic bladder. And spina bifida occulta is identified in the lumbosacral area. MRI will reveal a conus at the normal level. Children are often denied surgery because the conus is at the normal level. And this incontinence can be devastating for these children. Nobody wants to be their friend because they smell like pee all the time. They don't get invited to birthday parties. They get picked on. And then not to mention the injury that happens to kidneys and bladder over time. And so here we presented the results of 60 children who underwent lysocephalum to untether the cord with a conus in a normal position. So all of us remember the development of the spinal cord. So you start out with the neural plateau, and it folds into the neural crest, then the neural tube, and it forms like a zipper from the middle going up and down, zips all the way down to the brain and to the bottom of the spinal cord. And on your anatomy in the embryo, you'll see that the cord is the full length here. And then by the time you're born, the spinal cord will typically end at lumbar 1, 2, and then you have the filum terminale at the end. So one of the easiest symptoms to pick up when you're looking for tethered cord is incontinence or neurogenic bladder. And so there are three types of neurogenic bladder that you see. First is hyperactivity. Those is the kids that have frequency, urgency incontinence. They're running to the potty every 15 minutes, every 30 minutes. They've got to get there in 1 minute or they're going to have an accident. I mean, this is significant urgency incontinence. The second is hypoactivity, which is a low-tone bladder, which is a big distended floppy bladder that doesn't empty effectively, and they're prone to urinary tract infections because they don't empty the bladder effectively. The third type is detrusor sphincter dyssynergia, which is basically sounds like BPH, like an old man with a prostate problem. They've got high pressure. High pressure is required to void. It is, because women don't have it. And then there's reflux, poor stream, pain, straining to empty, and poor emptying. So these kids tend to have post-void residuals. And what's happening for the patients, what's happening with a dyssynergistic bladder is, you want your bladder to constrict and the sphincter to open. If they're not working right, the bladder's constricting, the sphincter's constricting, you get high pressure voiding, you're not able to effectively urinate. So when we were trying to sort through these kids, they would all have to have a trial of conservative therapy, and have gone through behavioral incentives, giving you a candy or whatever if you're dry for the day, or whatever behavioral incentives, strict time voiding regimens where they pee routinely every 2 hours, you do it by the clock, Kegel exercises, and then anticholinergic therapy like ditropan. And when we're talking about kids that are having incontinence, I was looking at the series you're having, and the Australian kids that 16% have one accident in 6 months. Well, I'm sure Petra will tell you we're not talking about kids that are having one accident in 6 months. We're talking about when we're looking at kids that come to us for possible urinary incontinence, they're having multiple accidents a day. They can't get through the school day without peeing their pants. They smell like urine every day. I mean, this is not, maybe once in 6 months you might pee in your pants because you're at the store and you drank a big soda and you didn't get there. We're not talking about that kind of a kid. We are talking about a kid where this is causing him serious psychological trauma. He's getting picked on, he's getting beat up, and in these days of the internet, where you can imagine you pee in your pants and it's all over, the internet on Facebook, it's just, it's a real issue for these kids. Now, all of the patients that I do, I have to see spina bifida occulta. And so spina bifida occulta, you could see it, usually it's in L5 or S1. So spina bifida occulta, during neurodevelopment, the spine closes. Remember, we were looking at the neurodevelopment picture earlier. And so sometimes there's a gap there. But spina bifida is common. It's in about 10% of the population. So just because somebody has spina bifida occulta doesn't mean they have a tethered cord, but just about everybody with tethered cord has spina bifida occulta. So you can kind of use it as a screen. And my urologist will say that about 1 in 20 of his kids that he sees for incontinence, he'll see spina bifida occulta, and in that situation, if they have other qualities, then he would refer them on to me. So we, in this series, looked at 66 kids who underwent lysocephalum to untether the cord. 6 were lost to follow-up prior to our 6-month window. So it's about equal male to female, 32 male, 28 female, and our age distribution was age 3 to 18, mean age of 8 years, follow-up 6 to 37 months with a mean of almost 14 months. And we did this by review of chart notes, and if we didn't have the information, we called the patients. We had a nurse practitioner who was calling patients to get the results if we didn't have it. And so we were able to get follow-up for greater than 6 months in 60 of the kids. So the presentation, urinary instability was the main presentation we were looking for in this group of kids. Nowadays that I've been doing this for 20 years, it's not always urinary instability that's the primary symptom. Sometimes it's encopresis, bowel incontinence is the primary component, but usually you will see both bowel and bladder involvement. Urgency frequency was in 58%. And this is, again, significant frequency. It's going to the potty every 30 minutes, every hour. And the real key to this is finding kids that have secondary incontinence. There are some, with primary incontinence, it's more difficult, kids that have never been able to potty train. But the kids that are real red flags for me are ones that potty trained on time, average kid 2.5, 3, potty trains on time, does well for 6 months, a year, 2 years. Then as they grow, start to develop incontinence. And, people will always say, there's a new baby in the house, or, mom and dad got divorced, or, whatever. They'll come up with some reason that they think the kid is having secondary incontinence. But that is a big red flag. And so 47 of our 54 had secondary incontinence. One of the kids had urinary retention, and this was the reason that I started doing this procedure 1,000 years ago, was because my urologist came to me with a 2.5-year-old kid who had a Foley in place for a month because he had urinary retention. He also had some gait changes and some bowel issues as well, but couldn't pee. And he brought me the article from, I think, Selzuki in Turkey was one of the first people to write about this. We cut his filament, and when he took the Foley out, about 3 days later, the kid could pee again and never had another problem. And so that was the first one I ever did. Chronic constipation is present in about half the patients, and by chronic constipation, I don't mean that takes the kid a long time to have a bowel movement. I'm talking that these kids are on Miralax or suppositories every day because they can't go to the bathroom. Fecal incontinence is present in about 53%. Nighttime accidents, nocturnal enuresis is present in about 47%. I don't really count that as a sign of tethered cord because, so many kids with nothing else wrong with them wet the bed. There's usually a family history, usually has to do with sleep patterns. So I don't count that as a big factor, but I do pay attention to it. Recurrent UTIs are present, and we talked about that again with the low-tone bladder. Gait changes in about 40%. This is usually seen as, one of the most common things I hear with the parents is that he can't run correctly anymore. The kid doesn't run right anymore. He used to be, one of the fastest kids. Now he never picks, the thing I hear most commonly is he doesn't pick up his knees. He doesn't run right, and I think this is from increased tone in the legs over time. A lot of them do develop toe walking. And yes, toe walking is common in little kids. But if you ask all your orthopedic colleagues, they will tell you by about 4 years of age, if they're still toe walking, there's something going on. And there are families where everybody toe walked, but if it's still going on past 4 or 5, then something's going on. Back pain, leg cramps, these are all things that you look for. And we're talking significant pain. We're not talking the kid that goes to bed, and for a few weeks will have pain at night that's growing pains. We're talking pain that makes the kid not want to do anything. They don't want to do any sports. They want to be carried, after they've been walking around in the store for 5 minutes. And these are significant symptoms. They're not something that you have to look for. They have to be something that's really a problem. On physical exam, reflex abnormalities were present in 82%, hyporeflexia in 16%, but more commonly I see hyperreflexia. Petra, I think you saw the same thing, mostly hyperreflexia. Weakness in about 35%, and that's usually hamstrings or extensor hallucis longus are the two muscles that I typically see. Cutaneous stigmata or muscle tone abnormalities, increased tone in the lower extremities. A lot of times the kids can't get anywhere near touching their toes when you have them bend forward to touch their toes. So sometimes they have difficulty with that. A lot of times they can't get their hands past their knees when they're bending forward. Cutaneous stigmata I found in about 12%. So a lot of people will only look for these kids if they have a sacral dimple or a hemangioma or hypertrichosis or something. But I find that that's not necessary. But I do like to see the spina bifida occulta. Sensory disturbances in about 15%. That's usually pain or decreased sensation in the perineal area, the saddle distribution. Scoliosis or exaggerated lordosis in about 10%, and then abnormal VCUG and ultrasound in 25%. Typically on the ultrasound, you're going to see a thickened bladder wall. It'd be typically what you see. Or on the VCUG, usually a post-void residual. So, I was trying to find a way to sort out how to determine who has a tethered cord and how to make the diagnosis. And so the criteria I came up with back in 2000 was progressive bladder instability. It has to be something that's getting worse and worse, not just a kid that has an accident every now and then. It has to be getting worse over time. And if a kid's having accidents I'll give them at least 6 months to make sure that they're getting better, and if they are not getting better after 6 months, then I start to worry that we might be getting into the point that they're going to develop some injury to the cord, and I think a lot of times the things that we see with people that say, oh, my results aren't very good when I did this, and if the people's results aren't very good when they do it, it's because they wait until the kids got end organ damage or the cord is injured. If you wait, I haven't read Paul's recent study, but the one, if he waited 5 years for the kid to be symptomatic for 5 years, he's probably got a little scarred down bladder with diverticuli in the bladder and recurrent UTIs. And if you wait a long time, that's why a lot of times when we do adults, we can't recover the bladder function. We can usually improve the pain, but if you've got end organ damage, you've got end organ damage. So, that's part of the problem. So I wait until I'm sure, but I don't wait until I think they can't recover anymore. So I'll usually give them 6 months of instability and see how they do. I don't consider a kid to have primary incontinence until they're 5 years old. Because some kids are just slow to potty train. And if they're 5 years old and they are still having accidents, that's way out of the norm, and then I get concerned about that. Or if it's secondary incontinence, again, that's a red flag. So, and then we like to see spina bifida occulta is the second thing I like to see. I can count on one hand in 20 years the kids that I've done without spina bifida occulta, but they had something obvious like a conus at L3 or something, And then I always have the patient evaluated by the specialty of primary complaint. So if it's incontinence, I make sure they've been evaluated and treated conservatively first by a urologist or a nephrologist. If it's GI, if it's incontinence, bowel incontinence, I make sure they've been screened and treated and looked at by the GI guys. If it's orthopedic, if it's gait abnormalities, toe walking, I make sure they've seen rehab and ortho, because I want to be sure that we've screened out all the basic stuff before we move to this, because to some degree, this is a diagnosis of exclusion, and we always try conservative therapy first. So I like to have those three things, and then 2 or more of these other following issues, and Petra talked about these, Dr. Yamada talked about these. These are the things that we see in our tethered lipomyelomeningocele, our tethered myelomeningocele. These are your classic tethered cord findings. Bowel involvement, lower extremity weakness, gait changes, reflex or tone abnormalities, sensory disturbances, scoliosis, orthopedic abnormalities or limb length discrepancy, recurrent UTIs, abnormal VCUG, ultrasound or syringomyelia, and neurocutaneous stigmata. So in my series of 60 here, remember we said we wanted the top 3, and then category 4, I wanted at least 2. The one that had just 1 was that little boy with retention. So we went on and did him because he was stuck with a Foley at 2.5, and we went ahead and bent the rules a little bit for him. But the rest of these, you can see when you look at the criteria, most of these people have 3 or 4 or 5 of these other criterias. And I make the diagnosis by constellation of symptoms, not just by, oh yeah, it's like you're saying, like our previous speaker was saying, well, you can see a kid with that has toe walking and say they have a tethered cord. No, I would have to see spina bifida, back pain, leg pain, coordination, balance issues, something. I'd have to see 3 or 4 things that all fit. And that's the way that I make the diagnosis. And I'm very careful about making the diagnosis because, otherwise you just have a cut on their back and they're no better. So radiographic studies, we want a lumbosacral spine, spina bifida of the lumbosacral spine. And in these patients, the conus was in a normal position, and I considered that at L2 or above. And the procedure is a lumbar laminotomy and lysis of the phylum. Actually, in most of the cases, I don't take any bone at all. My incisions are usually a centimeter and a half, I sneak in between the spinous processes, go down to the dura, make an opening of maybe 8 millimeters or so in the dura, pick up the file and cut it and get out. It takes about literally 20 to 30 minutes, even on a 250-pound 12-year-old like I did last week. So it's very quick, simple, safe operation. And in these situations, when you get in there, typically, even though you don't see it on the MRI, the phylum's typically a bit thickened, and you see the same. Typically at least 2 or 3 millimeters. Occasionally it's really thin, and those are usually, I find, the kids that are mostly bowel incontinence. But you'll see that the phylum always appears tight and is always dorsal in location. When you open there and you're looking at the dura, you will see the phylum pulled tight up against the dura, and it retracts briskly like a tight rubber band. And the way I describe the phylums to the parents, is that the phylums, they're like a rubber band. You should, you can see a rubber band and you can't tell how stretchy it is. And some of the phylums they're just it's a rubber band that's just tight. It doesn't stretch as much as it should. Then as the spine grows, you're putting more traction on that cord because the spine grows more than the cord, so you get more traction. So here's just an example of an MRI. And this is like Dr. Yamada was talking about. See how the cord is pulled posteriorly there, back against the spinal fluid sac, and it's ending at lumbar 1, 2. And when you look at this, you think, well, I don't really see anything too worrisome up and down there. The phylum looks okay, looks really normal. And on this kid, of course, they have spina bifida, but because I make sure they all do. But when you get in there, this is before. This is open, but this is before. You can see that phylum pulled up tight against the dura. And then once we open the dura, this was a big, fat, honking 8 millimeter phylum, and you can't see it on the MRI. You didn't see it, and that's just the way we see all the time. And this is another one that has the conus at L1, 2. No, you don't see anything suspicious here. Radiologist thinks it's normal. And then on the before I move off of this, I don't have the cines on here. I wish I did the cinematographic. When you on a cinematographic MRI, and I've been looking at them for about 15 years, the tip of the conus will typically move in a cylindrical fashion. It'll go up and down and forward and back with every heartbeat. And when it starts to get moderately tight, it'll just jiggle front to back. And when it's really tight, it won't move at all. And that's just another piece of the puzzle that I look at. I never make a diagnosis just based on that, but that's another factor that I look at. And so then here you can see the phylum back in this area, pulled back on the axial cut. And then when we got to surgery, whoops, you can see the phylum here. This is a little nerve hook picking up the phylum. This is the phylum. These are little rootlets. But see how it reminds you like when you're trying to tie a Christmas ribbon and it's really tight like that? You can see how tight that is. So the results that we got were urinary instability, urgency frequency improved in all of our kids, and urinary retention. I was trying to find incontinence and retention. I mean, I looked at the results of these and they were too good, so I had to try to find a way to make them not look as good as they were because they just looked too good. So urinary incontinence, I said resolved when it went completely away in 52%, and improved in 46%. And then I divided this up. Near complete resolution was better than 95% resolution, meaning if they had 20 accidents before, they have one now. 20 accidents a week, now they have one. So I consider that near complete. And then marked improvement was 75% improvement. Moderate improvement was greater than 50. And I considered unchanged if it only got better by half, less than half. So if they went from 10 accidents to 5 accidents a week, I considered that unchanged. Bowel incontinence resolved in 56%, improved in 41, and was unchanged in one patient. The one that was unchanged for bowel and bladder was a primary incontinence kid. So when it's primary and they've never potty trained ever in their whole life, the bets are off. You don't know if maybe there's just something else wrong, if things just didn't grow right. The kids that I really expect to get better were the ones where we know the hardware's there, we know it works because they were able to potty train. Then as they grew, it all went backwards. Nocturnal enuresis actually got better, or resolved in half, better in 25%, and unchanged in 29. That's another one of those things that I think has too many other factors involved in nighttime. And so I never operate on somebody who shows up and says, my kid wets the bed. And I'm like, well, a lot of kids wet the bed, I don't ever use that as an isolated criteria. Recurrent urinary tract infections improved in 2/3 and were unchanged in 1. And again, this is at my, average of 14-month follow-up. A lot of the kids with UTIs have injured bladders. They've got little vesicles in the bladder wall now, and they reseed over and over again, and they are difficult to treat. Gait improved in all of the kids. Weakness improved. Weakness is the easiest thing to get back. Of everything. Sensory abnormalities resolved, the pain improved. Now, some of our kids now that I see that are older teenagers that have really bad chronic pain take a little longer for that to get better. A lot of them you'll see relief right away, but sometimes they'll rebound and then go away. And we do see different patterns of recovery. But pain was relieved in these kids, these early ones, on straight away. And then scoliosis and lordosis stabilized or improved. And we didn't have any operative complications with this series. And still, I've only, in 20 years now of doing this operation, have had 2 kids that had spinal fluid leaks where I had to go back in, and that's it. And they were kids that went out and played baseball 2 days afterwards and stuff like that. And so in conclusion, children who meet these criteria for tethered cord with spina bifida occulta may benefit from lysis of the phylum even if the conus is in the normal position. So this is criteria I've been using for 20 years, and found it to be pretty helpful in doing it. And I do think a problem that we do have, as we were discussing earlier, is that everybody has a phylum, so you have to be real careful who you do. And I always am very, very careful, because if you start doing kids that don't have the problem, then you're not going to have 90% success, because you're doing kids that don't have the problem. But on the other hand, you do have to remember that it is a simple, easy, straightforward procedure with virtually no complications in virtually anybody's hands. I mean, people rarely have a problem with this operation, and you have to weigh the risk and benefits, but you got to be careful. And so I look forward to the questions.
Thank you very much.